Welcome to This Week in Health IT, where we discuss the news, information, and emerging thought with leaders from across the healthcare industry. This is episode number 16. It's Friday, April 27th. Today, we break down the changes in the program formerly known as MU and what this week's announcement by CMS means to health IT. We also get an update on Apple's health record initiative from one of the users of the technology and a lot more. This podcast is brought to you by Health Lyrics. Get ahead of the wave. We believe every health IT organization has it within them to be great. It all starts with clarity. Visit healthlyrics.com to schedule your free consult. My name is Bill Russell, recovering healthcare CIO, writer, and consultant with the previously mentioned Health Lyrics. Sometimes on the show we have people I've interacted with a lot, and sometimes we have people that I've just interacted with from afar, read their stuff, read interviews, and the things they say resonate with me, and I look forward to them being on the show. And then I make the request, and they say yes, and I'm really excited when they actually sometimes it just surprises me when people say yes because of how busy CIOs are. Today, I'm really excited to have Tressa Springmann, CIO for LifeBridge Health, on the show. Tressa, welcome to the show.
Thanks for having me. Good morning and happy Friday.
Yeah, happy Friday. Casual Friday for you, casual Friday for me. It's I think most healthcare IT organizations now are casual on Fridays, aren't they?
Yeah. I know it's something we enjoy. It just inspires a little bit more informality in the day, and it's a pregame to the weekend for sure.
Yeah, I think Sarah Richardson was trying to push for 2 more casual days during the week. I don't know if she's going to get there, but healthcare is still pretty next to finance is still a pretty buttoned up kind of environment. So let me give some of your background here. So Tressa's CIO for LifeBridge since 2012. LifeBridge Health is about $2 billion. You also took on the role of performance improvement. A lot of times people are asking me, where does the CIO go next, or where do they expand to? And so you've taken on performance improvement. We'll talk a little bit about that. And so LifeBridge, $2 billion, 10,000 employees, located in Maryland. You're highly active in various things within the community. Chairman of your health information exchange called CRISP. You're part of the advisory board for Towson University on their healthcare management program. You're an adjunct professor at Mount St. Mary's University, previously teaching HIT, which is awesome, for their master's program. You're the past president of Maryland HIMSS, certified professional in health information systems management, and also a CHCIO. And you have your master's from Johns Hopkins and a BA in biology from St. Mary's College of Maryland. Is there anything I missed? Like, you have a family that you're really proud of, or anything like that?
Yeah, I think those accomplishments really trump the litany of what you read. Yep, I right now live in Maryland. I've got 2 sons and 2 crazy dogs. And I am actually tonight struggling to get through turning in my final exam for a wine chemistry class that I'm finishing up at Penn State. So I got a lot going on, and I appreciate you having me here for sure.
Well, thanks. Wine chemistry? No, the show's too short to go down that path. We'll be talking for hours.
All right, for another time, for sure.
So, Maryland, I don't think people recognize this, but Maryland's kind of unique. They're 3 years into a 5-year agreement with CMS and Medicaid. And I think that if I remember correctly, because I did interview for a job there at one point, and it's sort of an experiment on driving spending down and improving the quality of care. Can you give us a little idea of how that's unique and how that maybe impacts health system that's operating in Maryland?
Sure. Wow, I've got to do it succinctly. So we have a waiver from Medicare, and we are identified as an all-payer state. So I'll just talk about that for a little bit, because we've had the waiver for quite some time, but it was modernized, as you inferred, about 3 years ago. And that made a big difference now in our reimbursement. But basically in Maryland, there's a commission that sets rates for different hospitals. and it allows us to offer access to all payers. So if you come to one of our hospitals or any hospital in Maryland, no matter who your payer is, the price is the same. So we are assigned what we can charge, and what we can charge is the same for an appendectomy, for example, no matter who your payer is. So it's an all-payer state. It's helped reduce barriers and access to care for sure. But what's really become quite novel is a handful of years ago when we modernized the waiver with the intent to reduce the increase in the Medicare healthcare spend across the entire healthcare industry in Maryland. It put on the shoulders of Maryland hospitals a fixed budget environment. So we, not budget, but revenue. Every year now, our hospitals are getting a flat revenue amount for the number of patients that we see. Now, it's much more complicated than that. It takes into account market share, and it takes into account regulated and non-regulated space. But the reality is that we are very much at risk for anyone that walks in the door. And it is very much in our best interest to manage our patients at the right level of care, because we're getting a fixed dollar amount irrespective of who we're serving.
So it's been right now with the things I'm reading, it's been successful. Has it been successful from a health system perspective?
It's been hard from a health system perspective, because even though the hospitals are getting a fixed payment, the rest of the healthcare industry is still fee-for-service. Our physician practices, our urgent care, our post-acute, they aren't on a fixed revenue model. And so this next year, if you think about a balloon full of air, the hospitals have done a great job squeezing into the cost and enhancing the quality because of this appropriate incentive structure. But that balloon has the same amount of air, and what we're seeing now is that it's just burgeoning out a little bit of the expenses on the fee-for-service side of the equation. So the next challenge in front of us is really to come in under the numbers on the total cost of care, not just the hospital-based cost of care. And yet doing that, understanding that a lot of other aspects of the industry are going to remain on a fee-for-service model. So LifeBridge has aggressively created partnerships and joint ventures and our own aligned incentives that really focus on taking care of a shared patient population, knowing that ultimately this is a really good environment for patients.
Yeah, it's interesting. That could be a precursor to what comes across the industry. Who knows? It is built sort of as a pilot. Started, as we said, a number of years ago, and really, I don't know that it'll end. It sort of has a 5-year time frame, but I'm not sure it's going to end. What we like to do is we like to ask our guests, what are they working on right now that they're excited about? That that's really interesting.
There are a lot of candidate ideas there. Right now, we've had a very successful year evolving our telehealth strategy. We've got 7 very unique first-year pilot use cases, but a much broader strategy that we're taking on in the coming year, and really wrapping our telehealth strategy around an entire digital health platform and integrated with both a clinical and administrative call center to really strategically move forward, reducing barriers and access to care. Whether it's scheduling an appointment, talking to a clinician, or just figuring out, should I go to an urgent care or a primary care or the ER? Really creating choice points for our patients, whether they want to interact with us in person, over the phone, or in a digital experience, and making sure that we make that customer service interaction an easy one. Yeah. We all know how siloed our industry is. And so I'm just super excited about the opportunities that this provides.
Yeah, and we're seeing a lot of that. I've visited a couple of health systems this week, and what is going on in the telehealth space is really exciting. We just hope that sort of reimbursement reform and whatnot catches up, so that you know that the payment models match the technology and the desire that we all have to make it easier for the patients. So this is how the show breaks down. It breaks down to the three segments. We do in the news, we do leadership or tech talk, which we're going to change up a little bit again, and I'll explain that. And then we do social media posts to end it. And sometimes in the news, the show just writes itself. This is one of those weeks. Tressa and I got on the phone earlier this week to discuss, what topics do we want to talk about, what stories are in the news. And I think we talked on Monday or Tuesday, and then CMS did their announcement, and that sort of became the prevailing news story. So that's what we're gonna jump into. There's any number of places you can read about this. The CMS website is probably the best. It was pretty clear description of what's going on. So here's the first. I'll set this up, and then we'll go back and forth a little bit. So CMS proposed changes to empower patients through better access to hospital price information, improve the use of the electronic health records, and make it easier for providers to spend time with their patients. So that's the first line of the CMS. Here's a couple of quotes from CMS Administrator Seema Verma. We seek to ensure healthcare systems put patients first. Today's proposed rule demonstrates our commitment to patient access to high quality care while removing outdated and redundant regulations on providers. So that's the gist of what they did. The EHR adoption has created electronic silos. We had filing cabinets before, now we have electronic silos. Data doesn't mean anything unless it's put into a format that's meaningful to the end user, whether that provider or a patient, whether it be for a provider or a patient. That is where we will be continuing to focus our efforts. So that's why and a little bit of what. So let's actually take a look at what happened, and then we'll get into it. So specifically, CMS plans to change the EHR incentive programs in the following ways. They're going to make the program more flexible and less burdensome. They're going to emphasize measures that require the exchange of health information between providers and patients. And they're going to incentivize providers to make it easier for patients to obtain their medical records. So this is where it starts. They renamed it, right? So it's the program formerly known as MU. So we're doubling down on these efforts. Our announcement to complete the overhaul of meaningful use is for the first installment of that, she said, referring to the recently announced renaming of EHR incentive programs to promoting interoperability programs. Interoperability, so renaming is not a small deal. It shows the focus of it. And the focus of it, as we've highlighted on the show before, has bipartisan support. So this, what is generally accepted is that we created this environment where the data gets housed in these EHRs, but patients don't live only within one health system or only within an acute or an ambulatory environment. And a lot of times they are moving across a continuum, and we've created these silos. And as people like Vice President Joe Biden have traveled around in support of the program, the foundation that he's supporting, he has heard over and over again that this is one of the major things that's holding back research, it's holding back good care, is interoperability. So they rename it, has bipartisan support. We're going to sort of move forward on that. So here's where we start going back and forth. Here are some of the patient-centered improvements. The first is patient has access to the record in downloadable format the day they leave the hospital. Okay, so that's one aspect of it. The second is, the quote here is, when we go to the doctor's office, we want to be able to have the information about what happened there. We want to be able to build our record from birth through our entire life. You want to be able to aggregate information from your medical record and from your devices so we can put the story together and see your health and how it looks. So what we're saying is now the patient becomes the center for that filing cabinet, right? So if wherever they leave, they're going to get that medical record in terms of interoperability. So what kind of impact, let's start there on that one. What kind of impact will that have on your health IT organization, and what kind of benefit do you think that would have for patients?
So Bill, I think that the meaningful use program, and we all know that it really started in the early days as use. It was use oriented,
Yep.
to get more clinical data and data use available in physician practices and in hospitals, and have it stored in a somewhat standard way. And it was a great way to begin, but it was from the healthcare industry out. And what I love about the pivot now is this recognition of a digital economy and consumer and patient comfort with technology. And I'm just a huge believer that whether it's 2 or 5 years from now, that the ecosystem is going to be much more in alignment where it needs to be, which is the patient in. This is about the patient. And, I envision a day where our consumers, patient, our citizens have the ability, because it's their health information, and they will move in and out of touch points of various participants in the industry, like LifeBridge Health, and they will be the ones providing me their history and their information, whether it's self-reported or from other areas and organizations. And I think that's a real paradigm shift. We've got to start with better interoperability between the entities in our ecosystem. But I think it's only a matter of time and velocity before it's really back in the very capable hands of either patients or their proxies.
Yeah. I think what people think is that it's just a matter of just opening up the data in a way it flows. Interoperability is a very complex thing, as I found when I came into healthcare. Our clinically integrated network literally had 100 different EMRs, and it wasn't just a matter of, okay, let's get the data. I mean, there's contractual agreements to move the data. There's the data itself. How clean is the data? The format it's stored in, the quality of the notes. The efficacy of the notes as well. I mean, there's just a whole host of barriers, and even within our 4 walls of our system, our clinically integrated network, our health system, we didn't have full interoperability.
Right.
So this is a challenge. I agree with you. I like the focus. So we are. Yesterday, I heard Rod Hochman, CEO of Providence St. Joseph Health, speak, and they have a simple moniker for their journey. It's know me, care for me, ease my way. And it's very patient-centered. It's really what we're looking for as patients. When we see the doctor, we want them to see our record and know us. We don't want them asking us all the questions again. We want them to care for us. We want the best outcomes. And ease my way is the part that's really starting to become central to healthcare now. It's, reduce the friction. I mean, that's the new buzzword. It's reduce the friction of the transaction. What do you think? Well, actually, we're going to talk about this in the next segment. So we're going to talk about your Apple Health record, because I think this is part of that. So let's go on to a couple of these others. This is an interesting one. So price transparency. Now, you're already required to provide price transparency as a hospital, but what they went one step further, and they said, yeah, now you have to provide price transparency on the internet in machine readable format, meaning a new company, a new tech company could come out, collect all these machine readable pricing information, and provide a sort of a snapshot of pricing. Is that going to, first of all, is that going to be hard? And I mean, from a technology perspective, probably not that hard, but is that going to be hard for you guys to do? And do you think that will have much of an impact today?
So Bill, I am, bar none, any one of us in Maryland are the worst folks to ask about this, because we don't negotiate rates with different managed care companies and insurance companies. We are given our rates. And so I actually look at that requirement and scratch my head and wonder, wow, is this going to be a requirement for us in Maryland, when in fact we really don't have prices? We have rates that are dictated to us by a commission. So, we can make them visible, but they really are not our prices. So sadly, I can't really respond in an effective way to that. I think that I would be misspeaking if I could talk about how easy or how challenging it is for people outside of Maryland. But for me, that is the singular element of the announcements this week that really gave me pause for thought, because I thought, here we go again. We're starting with a new approach to this. This meaning the program, and yet there are already elements that many of us, and I know we're still in the comment period, so the people in Maryland will be speaking to this, that it's a great and it's the right idea, but it's really not relevant in our little geography here.
Yeah, and I can see that. I think what they're trying to do is create a market, right? So if you have transparency, you have a market. I still can't choose any doctor. Like I can't go to Kaiser. Kaiser's sort of their own little island. If I wanted to in Southern California, I'm sort of restricted based on my plan. So I'm going to cover the last two real quick because I really want to jump into the next section. So they're reducing the burden, and this is no small deal. And every time I post something on social media, Dr. Green is quick to jump on it and say, MU has been a failure and those kind of things. And, this interoperability is a big reason why MU has not realized its potential. And the second is just the burdensome reporting on this thing. So they're going to reduce, let's see, the proposed rule will reduce the number of measures. Acute care hospitals are required to report across 5 quality and value-based purchasing programs. These proposals will remove a total of 19 measures from the quality programs and will deduplicate another 21 measures. And I'm sure that's going to be welcome. We had people dedicated to that, actually. I mean, it's a significant deal. And then the last thing just to note for health IT is the 2015 edition certified EHR technology must include API capabilities. And that is what is going to be required for the 2019 certification is the 2015 edition. And that is to drive APIs. And there's a belief in the industry, and I share this belief, that APIs will enable a new ecosystem of players. We want to be able to invite we want to be able to invite people from outside the industry, even from within the industry, to develop new ways to drive patient engagement and being able to care for people outside of the normal visits. I'm sure we will be talking more about this topic over the next couple of weeks and months, but thanks for getting us started. So our next section, I want to jump into your experience with the Apple Health Record. So you're one of those. You weren't the first small group, but you're a fast follower, as they say. So tell us what your experience has been so far with implementing the Apple Health Record app at LifeBridge, and just give us a little background on it.
Sure. LifeBridge prides itself on being sizable enough to fund innovation and yet small enough to be nimble. So when I saw the announcement by Apple about the 12 initial health systems, and I realized that a handful of them were either just down the street or in fact had a similar EHR infrastructure similar to ours, I got on the phone and I started talking to people about, hey, if you've done this elsewhere, do it with me, and I'm next and I'm ready and we can do this really quickly. We talked about interoperability as a key facet of our next generation meaningful use. And in fact, the Apple app is utilizing Fire APIs. So it's really a very classic example, number one. Number two, I talked about our passion and interest in accessibility. And if we step away, and sometimes that's hard to do as an executive, but if we step away from the organization that we serve and we look at the greater healthcare community, to the point that you mentioned, we on our own healthcare journey, either our own or our family, either our insurance or our preference, is navigating the places that we go within the industry. There's economics, there's our care condition, there's our pocketbook, and all of those influence our journey. And as much as I want stickiness and believe that healthcare delivery at LifeBridge can be and should be the sole provider for people in Baltimore and in Maryland, that's just not the case. And so definitely we subscribe to reducing barriers and access by giving you your information. And so what does that mean? Here in Maryland, Hopkins and MedStar and LifeBridge are all now participants. Within, golly, 6 weeks of that phone call, with the publication of the upgrade of the Apple app, the health app, the one with the little heart on it, as long as you have set up a portal at LifeBridge Health or any of our physicians that are affiliated in using our enterprise EMR, you can go right into the Apple app and see a more Apple rendering, an Apple-oriented rendering of your health information that you would find in your portal here. Now, it's not as interactive or robust as the portal app that our EHR vendor has that we have made available on smartphones for folks who visit us, where you can schedule appointments and ask secure message your clinicians and the physician practices. But what it does offer is if you're that person who has had to navigate to a MedStar facility, a Hopkins facility, and LifeBridge, and have had to establish portals, because we all remember how hard that meaningful use portal requirement was, especially for hospitals. Like, it's sad if you've been in a hospital yourself so very many times that you need to establish a portal. We see that much more prevalent in our physician practices, and maybe a much more reasonable ask, but that was a high hill to climb on meaningful use to make that measure. And yet now, with the Apple app, the health app, you've got the ability to visually render in real time through Fire API a view of your health data from all of our organizations on one app on your smartphone. So think about that. Apple has created that layer above so that these information silos have really just been kind of wiped away.
Yeah, so we're ending the portal ping pong, as it were. Was it hard? I mean, obviously your EHR platform, which I assume is Epic, am I right? Oh, okay. But had the Fire API, so this was it was a pretty straightforward implementation?
Yep. Wow. It really was. I think, probably the toughest thing was looking at all of the expectations that Apple has that are somewhat non-negotiable because they're Apple.
Yeah, but you're also sort of minimizing expectations here. I mean, it's not, it's a start, right? So it's bringing in certain sets of data. It's not as robust as your portal, but if you are somebody that moves around from system to system, now all of a sudden, instead of having my parents have this, a portal for one health system, a portal for another, a portal for another, you can at least, you can see what it might look like in 2, 3, 4 years. We still have some of the same challenges. I mean, getting a common med list is almost impossible, right? I mean, if you have a med list from LifeBridge and you have a med list from a discharge at Hopkins, reconciling those is very challenging. It was challenging in the portal world. I'm sure it's going to continue to be challenging in the Apple world, but but we could do the 80-20 rule and say, this is 80%. We now have the patient giving them a good snapshot, at least, of where we're at today with their health. Is that how you're looking at it?
That's right. That's right. I mean, look, I look at it as a baby step. If I pull it up on my phone and I've got my own records in there, it's a nice visual, it's aesthetically pleasing, it's very Apple-ish, but I can't do a lot with it except look at it. But it's the right step, and conceptually, it's a disruptor where there's sufficient industry interest in what does it look like and what can it become.
Yeah, it's interesting. What do you say to the people? So we just had this Facebook thing, and people inadvertently shared their data. And one of the things that people like to point to with Apple is you're going to have the ability to share your data with a provider, or at some point you're going to be able to walk into any health system and say, would you like a copy of my record? And click a button and your Apple Health record will go over, and they'll at least have that at the point of care. But what privacy people are saying, and some high-powered industry people are saying, is if we give people access to their health record, they're going to get duped and they're going to give away their health record. I mean, clearly it's a concern, but are you more worried about that, or are you worried about that? And how, I mean, how do you balance that with putting people in the driver's seat of their health?
Yeah, wow. So, we are always striking that balance and um, on a daily basis. How rigorous and strong do you make authentication and passwords? And yet you don't want it to be a barrier to having your clinicians easily get in and be able to access information on the patient so that they can render care. We're continually teeter-tottering on in an imperfect world. So look, I just think we're going to have to continue to navigate that for sure.
Yeah.
One might argue that when you've got all this data that's accessible, and I know our physicians argue it, they're like, whoa, if it's out there, does that mean there's an expectation that I knew it was there, I looked at it, and I'm accountable for it?
Right.
That's counterbalanced with the clinician saying, wow, if we put it completely in the hands of the consumer or the patient, and they're electing not to share it with us, that could be pretty damaging too. I think the reality is, as a patient, as a consumer, that's really mine. It's mine to make some determination over. And yet I think many people would agree that in a circumstance where, let's say there's a horrific accident, you're in a car accident, you arrive unconscious in an emergency room. That's a circumstance where people can really wrap their head around the fact that they'd rather have their care providers have access than be overly concerned about the wrong person having the ability to take care of them by having a barrier to that information. But I think it's going to introduce a whole different level of conversation and complexity, for sure.
Yeah, I agree. And the thing I would say to the leaders at Epic and Cerner, who quite frankly benefit from the data being closed off, I think they're great people. I think they want to do what's best for healthcare, but they are sort of proponents of this. Hey, we've got to protect the individual. And again, I've had these conversations and kind of abruptly ended them by saying, how can an individual do much worse than the 24 million records that we've breached since 2016? I mean, quite frankly, I'd rather be responsible for breaching my record than just continually getting those, we'll protect your credit history emails from the various providers that have had my record over the years. I'm not gonna have you comment on that because I don't want you to get into the same trouble that I get into.
You got it.
Yeah. All right. So here's what we're going to do. And we're going to have to do this fast because we spent a lot of time. So this is really mostly, I'm going to change this to sort of a soundbite segment. I'm going to ask you 6 questions really quick and, 1 to 2 minute answers on these things. So what is one technology that has the potential to have the most impact on healthcare in the next 5 years?
Do I get a whole minute to think about it?
No, you have a minute to answer.
So I have been really impressed with technologies that are starting to emulate the human senses, right? We all are learning a lot about voice recognition and optical character recognition and taking advantage of voice commands. I'm starting to see the same with machine vision, where just the ability to leverage and take the sense of vision and apply it to framing out geographic awareness in an OR or navigating a healthcare physical hospital. So I think we're going to see, obviously it's a lot of artificial intelligence, but I think getting very good at using those technologies so that we can revolutionize and make much more effective how we're gathering information, both from patients and providers.
Augmented intelligence. Computers are taking on a different role. It's very interesting. So every industry that has digitized has gone through this disruption really about 10 years post-digitization. We heard that at the Chime Forum. In 2008, 9% of the industry had EHR in place. Today, that number is about 90 to 95%. What are you doing to prepare for disruption or to promote disruption within your health system or your markets?
Right. Yeah, well, we definitely promote disruption. So I know we talked about meaningful use and the new program. And look, the reality is, as a CIO, we live very practically and need to demonstrate competency in budget management and keeping the lights on and addressing the regulatory challenges ahead of us. But I have a real mindset that our real opportunity is to differentiate by innovating around the edges. We want to keep our core sound and well controlled and reliable. And yet, if we, as one of the technology experts in a healthcare organization, aren't at the table partnering, whether it's with marketing to really enhance and address this new era of consumerism, or our innovation partner to work with different teaching institutions or startups, so that we can identify not only small tests of change, but perhaps ways to monetize or get very creative on finding different opportunities and funding sources to innovate, then we as the CIO are really missing out. So, I always encourage my peers, and I know organizations are structured very differently. You might have a chief transformation officer or chief digital officer. If that's not you, you need to lock arms and really be at the table for sure.
Yep. And, I appreciate you and industry and people in the industry that have organizations of your size. I heard a panel yesterday, and things like Dignity and Providence and whatever are talking, and it's $20 billion health systems, and clearly they're innovating. But when the smaller you are, the more creative you have to be in the partnerships you have to do. And your partnership with Apple is a testament to thinking creatively about innovating around the edge, as you said. Okay, so the work continues to change in health IT, and so I've been asking a lot of CIOs this type of question. We don't change tapes anymore. Well, you might change tapes. There might be some legacy systems, but generally speaking, tapes are going away from health IT. What is the one thing you're doing to prepare your team for the change in the work that is done within health IT?
Is that the bell?
That is the bell. We're going along. I apologize.
No.
We'll keep going.
We in information technology have been the catalyst for disruption for a lot of other players or associates in our own organizations. And yet we're going to have to change. And as a leader, I need to make sure that I'm creating and promoting an environment where there's a readiness for change and not the fear that might be attributed to displacing the way we've always done things. When we look at ourselves as a leader with a group of technology folks that span the skill domain from, supporting mainframes and network infrastructure, and when we start talking about displacing to the cloud and really creating maybe development roles that are much more around interoperability or digital health as opposed to the traditional programming mindset, it's super disruptive. And yet, like anything else, as a leader, we've got to manage the message. And I think we've got to take some of the fear out of that by creating a safe environment for the conversation, and really to continue to educate where the industry is going, and then personally commit to the organization I serve and the phenomenal associates I have working for me here, that there's going to be a place for them. They shouldn't be intimidated. It's still technology. It's still creative design. So even though the tool in their hand may be a little bit different, the motivation that got them into this space and into this industry will remain.
Yeah, as I tell my kids recently graduated from college and moved into the work world, and I think we're telling them now that they'll change what they do, 10 to 12 times before they retire. And when we came into the industry, it was, you'll change 4 or 5 times in your career. I'm not even sure that 10 to 12 is accurate. I think the nature of work will change so dramatically that what they're doing is going to be interesting. So what's one thing you would say to vendors trying to work with the health system? I got that email once that had dear whatever, it wasn't even my name. We have the greatest things in sliced bread. You need this thing. But I get this question a lot from vendors is, what's the approach that resonates with the CIO?
Well, with a name like Tressa, 9 times out of 10, they spell it wrong anyway. So thank you for the letter, but that's not me. Yeah. Bill, I think you can relate to this. And I can too. I've been a CIO now for over 20 years in a few different institutions, organizations, but that's not where I've always been. We have a passion for supporting healthcare as an industry and, as a commitment to doing a better job here in the US with health quality, health equality, and a more economic value to the quality of care. And I'm most appreciative when vendors or other people in this ecosystem that we're in approach us as peers and professionals. I think, as you know, we have all worn different badges and sat in different seats. And I think if there's a participation in the dialogue about how we can solve a problem, there's a higher probability that when we get down to the investments and tools, that we're taking advantage of the players in the market who we really know understand it. So yep. That may be kind of a philosophical comment, but I gotta be honest, maybe it's a bit arrogant. I pride myself on knowing the 10 big things I need to solve in the coming 3 months, 6 months, 9 months, yeah. And I go chase them down. So when I know I need it, I'm calling them. So just having a presence and recognizing that I'd rather talk about the problem that we're trying to solve together than any specific method of solving it usually takes care of itself from a product perspective.
Yeah, and similarly, I say 3 things to them. I say, know my business. So I don't want to keep educating you on my business. The second thing is, don't try to get to me through email. If you can't get to me through another person, you're probably not going to get the sale anyway. So either through a peer telling me, hey, you should talk to this person, or somebody within our system saying you should talk to this person. So that's the second thing I would say to people. And the third is, a traditional sales rep doesn't cut it anymore. When I talk to the sales rep, I want to be strategizing. I want them to know their product backwards and forwards. I don't want to, have a go between, oh, let me bring in this person, let me bring in this person. I want them to at least have a base level of knowledge that adds value to. Our time is valuable. It's the most valuable thing, which is why I appreciate you allowing us to go over today a little bit.
By the way, you were way more succinct in delivering kind of what I was articulating. That's a great list for vendors for sure. And if there's any, I hate to dwell on the negative, but please don't ask for an hour of my time to tell you what my goals are for the coming year. So that you can try and figure out what corner of that to sell into. I know what I'm going after.
So one of your we're going to skip the social media at the end, but to cut this off, but one of your passions is the CIO needs a seat at the table. And I want to touch on that as we sort of close out the show. So what does that look like? And if you were interviewing for a CIO role today, what would be the situation that you would say, yeah, I'm not going to take that position because it's not structured correctly? I mean, do you need to report to the CEO? Do you at least need to be on, a president's advisory committee? Do you need to have like a board subcommittee that you're reporting to? I mean, when you say a seat at the table, give us an idea of what you envision.
Yeah, I think the red flags for me is not being involved in organizational strategy development.
Right.
If I'm offered an incredibly creative technical job, I'm not interested. I am an executive leader who needs to continually balance how we use technology to enable and advance our mission, which is a healthier community. And so, it creates my own constraints for sure. I'm at a leadership table where I'm equally responsible for operations excellence, lean, project management, getting cost efficiencies and effectiveness out of our system. And yet I recognize that as we digitize healthcare, I have one of the biggest hands out at budget time. And I myself have to manage that conflict between being a fiscally responsible executive who understands what those trade-offs are when we make those decisions and when I advance it. So for me, the red flag is that you're just the technology expert and, just go take care of that for us. Make sure you understand what these new federal programs are. But when we're talking about starting a new clinical program or a merger and acquisition or, one of our key tenants at the board level that I'm just not part of the executive team. That would be a problem for me because I've had that benefit and privilege for the last number of years.
Yeah, absolutely. Have to be part of the table. I've seen the thing I keep telling CIOs is you're delivering outcomes. And if you're delivering outcomes, they're typically business outcomes. And if you're in those conversations, you're at the right level. I don't like I did not report directly to the CEO. I did not find that to be a problem because I met with the CEO fairly often. We were in the same room fairly often. And whenever there was, we're thinking about digital transformation, those things, I was always at the table. So that worked. I didn't have to report directly to the CEO. And I know a lot of CEOs can only handle so many people reporting to them, and they have to make decisions from time to time. Thanks for coming on the show, Tressa. How can people follow you?
Well, let's see. I am on Twitter at Tressa Springmann, but also hashtag HealthITChicks. But again, hashtag Tressa Springmann. I'm also on LinkedIn. You can find me either through Chime or at lifebridgehealth.org. Most of the time, I'm just hunkered down here doing a job that we do every day. But when I get the pleasure and opportunity to poke my head out, as you have given me the opportunity, nothing better to learn from our peers and to add value where we can. So I really appreciate our time, Bill. And I really enjoyed this. It was really nice to meet you. You've asked some provoking questions, and just thanks for the opportunity.
Well, thanks. I learned a lot as well. There's a great series interview done by Health System CIO View. It's a 4-part series. If people get the opportunity to go out there, I recommend it. There was a lot of great material in there as well. So you can follow me on Twitter at the Patient CIO. My writing on the Health Lyrics website. Health System CIO picks up my articles every other week, so you can just track them down out there. Don't forget to follow the show on This Week in HIT, and check out our new website, thisweekinhealthit.com. If you like the show, please take a few seconds to give us a review on iTunes, Google Play. Catch all the videos on the YouTube channel. We're now up to, actually with this show, we will probably crack 100 videos out there on the YouTube channel. thisweekinhealthit.com/video will take you directly over to YouTube. And please come back every Friday for more news, information, and emerging thought with industry influencers. That's all for now.